My name is Jeff Ibbotson, and I just want to give you all a very warm welcome from Geneva, Switzerland, the United Nations Institute for Training and Research, and the Global Surgery Foundation for this third series, third session of the NSOAP Manual Education Series. And this one is called Integrating an NSOAP into National Health Strategies. And we're very pleased to have some wonderful speakers today. And I just want to introduce our moderator, Dr. Catherine Chu. Dr. Catherine Chu is a specialty trained colorectal surgeon, and she spent the last decade working on strengthening surgical capacity at the district hospitals in sub-Saharan Africa. She has received her undergraduate degree at Stanford and at University of California, Southern San Francisco, and did her general surgery residency there as well. She also has a master's degree in public health from the London School of Hygiene and Tropical Medicine, and she's currently serving as the professor and director of the Center for Global Surgery at Stellenbosch University in Cape Town, South Africa. So we're very pleased to have Catherine as our moderator today, and I'll let her introduce the other speakers. And Catherine, I'll turn the floor over to you. Thank you very much.
Thank you, Jeff, and welcome and good afternoon, everyone from Cape Town, South Africa. As Jeff mentioned, my name is Catherine Chu. It gives me great pleasure to introduce our first speaker, Dr. Emmanuel Makasa. Dr. Makasa is a Zambian orthopedic surgeon and one of the defining leaders in global surgery. He has worked tirelessly on the political front to ensure that surgery is on the international health agenda, and was one of the leading co-authors of the World Health Assembly resolution stating that emergency and essential surgery is a component of universal health coverage. Currently, Dr. Makasa chairs the Southern Africa Development Community, or SADC, Technical Experts Working Group on Surgical Healthcare. He's the director of the WITS SADC Regional Collaboration Center for Surgical Healthcare at the University of Witwatersrand here in South Africa. And he's also a consultant orthopedic and trauma surgeon in Lusaka, Zambia. Welcome, Dr. Makasa.
Thank you so much, Dr. Chu, and thank you to Geoff. And I would like also to quickly thank the hosting institutions, Uniter, Global Surgery Foundation, PGSSC, and Johnson & Johnson for making this possible. I also would like to thank all the participants for coming to join. As you heard today, we're discussing integrating the NSOAP, or the Surgical Health Policy, the National Surgical Obstetric and Anesthesia Plan, and into National Health Strategic Documents and the pandemic response. So this is going to be a discussion, but we're going to present the case study using the Zambian case as we discuss this topic. As you know, or maybe you've heard, Zambia already developed the National Surgical Obstetric and Anesthesia Plan. We developed this and launched it in 2016, and it runs from 2017 to 2021. From the slide we show here, we show a picture of the Zambian NSOAP. And of course, underneath that picture, you can see the theme of the NSOAP, which is really aligned to the SDGs and of course, under universal health coverage. Please, let's have the next slide. So I'm going to quickly look at why do we have to integrate an NSOAP? Because as you know, this is a national plan, it's a strategy. But why do we have to integrate it in the first place? Now, integrating an NSOAP is really important because, first of all, as you know, most programs from the way back, even through the MDG era, were horizontal program, meaning it ran all the way from the center of governance, meaning the Ministry of Health, through the levels of the health system, tertiary level, secondary level, down to primary level, and into the community. And they were mostly horizontal. So they didn't communicate, they didn't talk too much to each other. So we had HIV, TB, malaria, all those programs running all the way. And if we develop an NSOAP and not really integrate it, especially in this era when we're trying to work in a horizontal way, meaning in a cross-cutting way, it becomes very hard for this NSOAP to gather any pace or even to be implemented. It then becomes a strategy that we develop and stands outside everything else. So the NSOAP, first of all, needs to be integrated because we're trying to avoid silos. And we also want alignment. The NSOAP is a new policy in many countries, does not exist. It has to be aligned to other policies and strategies that the governments have. Secondly, prioritization by government and cooperating partners or any other stakeholders is based on what is contained in what we call a National Health Strategic Plan. That is what the government, together with cooperating partners and stakeholders, agree to prioritize. Government has a lot of problems to solve, but they pick and choose at every time what they want to prioritize. So if the NSOAP is integrated into this document, which is the Health Sector Strategic Plan, then it gets prioritized, then it gets attention. And because it's prioritized, it can also receive financing, and it's easy to mobilize resources for its implementation. And within the government, budget allocation is always allocated to the things that were prioritized in the National Health Strategic Plan. So with those two already, prioritization and financing, then there is some guarantee that implementation can be done through, plans, annual plans that are made at the national level, indeed at the district and facility level. Let's go to the next slide. We also then should look at implementing. These are not all the reasons, but some of the reasons that we can give today. Look at where or when can we actually integrate an NSOAP. Next slide. So integration can be done at many stages. The first stage of integration should start with the development process of the NSOAP itself. At this stage of development, it's important that there are stakeholders from all other, key, partners within government, within the health sector, and outside the health sector are brought on board, because they know what they have been doing, they know what strategic documents they have, and it's important that they sit during and make part of the process of development of an NSOAP, so that their input is there, rather than developing something independent and trying to consult them. So from the development stage of the development of the policy, integration has to take place. As you know, the policy is mostly the political decision. Once the policy is developed, this includes not only, like I said, the NSOAP development, but also development of the National Health Strategic Plan or its revision if the NSOAP comes midway, and I'll give examples. Once the policy is developed and integrated at policy level, then the programs are developed from the policy. The programs is actually the technical framework of how the services will be delivered, how we translate policy into action. So even in the programs, there's need for integration of the NSOAP. And then finally, at output or at service delivery, which is the last box in gray, there is also need to integrate even at service delivery. So you just don't develop a policy and think that it will integrate on its own automatically. It never happens. It hasn't happened here. And we always have to follow through and ensure we integrate at policy, we integrate at program, and we integrate at service delivery. Please, let's go to the next slide. So looking at policy integration for us in the Zambian case, how did we really integrate? Like I said, once we developed the NSOAP, in the development process, we involved many stakeholders to ensure that they can already give input and make sure that there's alignment. Now, once the policy was developed, we were lucky that the NSOAP was developed at the same time that the National Health Strategic Plan was being developed. And if you can see, the NSOAP runs from 2017 to 2021. Even the National Health Strategic Plan was for the same period. So we managed then to integrate our NSOAP into the Health Sector Strategic Plan at that time. But like I said, the Health Sector Strategic Plan, even when it does not include NSOAP, it's always something that is revised periodically, maybe at least once before the end. And so even at revision stage, this NSOAP that is developed could be integrated. So we integrated into the Health Sector Strategic Plan, and the Health Sector Strategic Plan, if you look in the middle column, was integrated or is part of the 7th National Development Plan of Zambia. And this again runs from the same period, 2017 to 2021. And the 7th National Development Plan feeds into the long-term vision of the country to become a middle-income prosperous country by 2030. So you can see that we have maintained alignment. If you look at the themes of each one of these documents, they kind of speak to each other. That's very, very important. And so policy alignment is just not alignment to the health sector strategy. It has to align to the other bigger strategies of government, of the whole government, because the health sector strategy is just for health. The National Development Plan is for the whole nation, as well as the long-term plan. Let's go to the next slide. Now, this slide is just to prove to you, it's an extract from the Zambia National Health Sector Strategic Plan. And you can see we have the goals of the NSOAP during this framework of the Health Sector Strategic Plan, the objectives of building capacity at all the 3 levels as strategies, and then of course looking at equipment and also looking at commodities. So this is how our NSOAP is already integrated. There are some other things that I left out, but I just took this summary interventions that shows you how we integrated. This is a piece coming from the Health Sector Strategic Plan, not from the NSOAP, but it talks about how the NSOAP is going to be implemented. So then when we make programs and when we make budget at facility level, we look at these strategies and these objectives, and then we budget accordingly. Next slide. And then when we talk programmatic integration, as you know, surgery already exists. Surgical services already exist. They are not the best, they're not up to capacity, but they exist. And so do we then create a full program from the top again, like another vertical program, another silo? No, we don't. Because surgery already exists, it's a matter of trying to find entry points in the other programs that surgery supports. For example, I have just highlighted a few examples here of programs where NSOAP can be integrated. The quality improvement program, the monitoring and evaluation program is something that could be used to integrate the program. And through this integration, then we can always have periodic indicators from the annual periodic, performance indicators, from process indicators, from the midterm review. The Zambian NSOAP is undergoing a midterm review together with the health sector strategic plan. And of course, there's also the final assessment that happens at the very end, which then informs the next strategic plan. So this is very important, and we should ensure that our NSOAP is included there, because otherwise having a program with no indicators or with no monitoring and evaluation, then we really can't see how we are moving, which challenges we are having, and how we can try to improve that. Another good example I want to give quickly is the issue of human resources and research. In the Zambian situation, yes, we want NSOAP, and the key area of work should be the district hospital facility where we want to improve surgical capacity. But when you look at the human resource establishment, that has lagged behind, because what we call the establishment does not really have the position of a surgeon at the district hospital or an anesthetist. So again, you can see there's a mismatch and there's no talking to each other between the programs. So this is something that needs to be reviewed so that we can create that post at the district hospital, so we can then allocate and place the surgeons there so they can do the surgical work. Otherwise, then it will always be done by non-physician clinicians. And it's okay, yes, but there's always issues of quality and ethics that come with that discussion. But our main goal is to provide the surgeon at the district. And research should be to be done. When we do health research, we should include issues to do with the NSOAP so that we can generate the evidence and also any lessons that we need to learn. When we look at pandemic preparedness, my colleagues will address this later, but I can clearly say that even this program is already existing in countries. Many countries are setting up the emergency preparedness and response program. And this covers all hazards. So it also covers everything else. It covers infectious diseases like COVID-19 right now, but it also covers other hazards like accidents and emergencies, natural disasters, including war. So NSOAP should be integrated there. And for surgical service capacity building should be integrated there. For us already, like I said, during this COVID pandemic, the surgical teams are working and contributing very, very strongly, because the anesthesia component and critical care are the ones that are helping manage the severely ill COVID patients with life support, with oxygen supply. Those are skills and services that are really done by surgical teams. And so we can still contribute even during this pandemic, and we should ensure that we can contribute strongly and also leverage the investments that are coming into the COVID response to build our anesthesia capacity, to build our critical care capacity for use in other surgical conditions that we may have now or in the future. Next slide, please. This is the last slide. So there's also issues of integration, like we said, at service delivery, not only at the program and policy. So at service delivery, again, like I said, I'm going to start with a pandemic preparedness, and I want to pick again on the COVID-19. As you already know, in terms of prevention, the surgical mask, which we use in theater most of the time, has been very instrumental in the prevention campaign of preventing COVID-19. So we're already playing a role. It's part of something that comes, our tool that comes from surgical services. and it's making a contribution, and we should highlight that and ensure that it's recognized and celebrated, of course, and also incorporated. And then there's issues of life support, like I already quickly said, so I won't belabor that one. Our teams are contributing very strongly to manage the severe cases of COVID-19. And of course, the last bullet there about us leveraging the investment. We're having a lot of investments in the response to COVID-19 now, but like I said, what is really built is also the critical care, the life support that is needed, ventilators and all that. But this is also the same thing that we use in the management of our post-op patients, even during the operations. We go to the middle part, we talk about maternal health. Yes, NSOAPs could be integrated here because in maternal health, the challenges we have is difficult deliveries. And of course, any bleeding that may occur during deliveries because of tears or atonic uteri. As you know, these are things that are intervened or managed with surgical interventions. So already we can strongly highlight this part, and we can use that as an entry point to contribute to better maternal health. Even in gynecology, we also still have NSOAPs playing a role in the management of fistula that have resulted from difficult birth. Even cancer, cervical cancer is a big problem, and not everybody comes in the stage where there's just early stage, but most of them come very late, and it may need to remove the uterus and surrounding tissue. All that is surgical, and then NSOAP really here again, surgical capacity can play a role. Lastly, we can look at the non-communicable diseases. Many people have never really known that surgical services contribute to the reduction of the physical disability that results from the surgical disease. Most surgical disease cause physical disability, and the people that are afflicted cannot work, cannot do much for themselves, and they are not very physically active. And we know lack of physical activity contributes to the onset of, it's a risk factor for development of NCDs. So when we operate on our patients, they become more physically active, and therefore the physical activity reduces their risk for non-communicable diseases. But you can go further and look at the management of NCDs. Again, when you look at injuries and cancers, surgical services are very, very key. So in terms of service delivery, these are a few of the examples that I can give. There are many, many more. But the NSOAP integration in terms of program, in terms of service delivery, has to find entry points through which we can integrate it. The entry points are already there. And these parts of the health system have not been performing to full capacity because the surgical component has been lacking. Last slide. So that's in a nutshell what I had for you, basically talking about the policy integration, the programmatic integration, and the service delivery integration. We have to integrate at all those levels. Thank you so much, Professor Chu, for giving me the opportunity to speak.
Thanks, Emmanuel. What a fantastic talk. And it doesn't matter how many times I've heard the story about how NSOAPs were integrated into the health plan in Zambia. I'm always amazed at the success. And, I think that most of that is thanks to you. And we'll talk a little bit about that later, about how you actually managed to get the buy-in from so many key stakeholders within national government, because I think that's something that those of us in other countries working on NSOAPs find challenging. But let's segue next into a talk about Dr. Ki Park. Dr. Park is a Korean-American neurosurgeon, and he's on the faculty at the program in Global Surgery and Social Change, or PGSSC, at Harvard Medical School. He's been instrumental in this NSOAP series and in working on NSOAPs. He's also a member of the Expert Advisory Group for Surgical Care and Anesthesia for the WHO, and he's a diplomat of the American Board of Neurological Surgery. So without further ado, I'd like to introduce Dr. Ki Park.
Thanks, Catherine. Yeah, let me just first say hello to my fellow panelists, and also thanks to UNITAR and J&J for putting this educational series together. It's been incredibly informative and impactful. So yeah, next slide, please. Emmanuel gave an incredibly fantastic talk that looked at the idea that integration of surgical care is essential, and he divided it into at the policy level, program level, and also at the level of operational, right, at the service delivery level. That's a really good way to think things through, but you really have to start at the policy level to be able to benefit at the service delivery and at the programmatic level. So we're going to do a little bit of a deep dive into the intersection between the pandemic preparedness and surgical system strengthening. You could argue right now that governments are so engrossed with responding to the current pandemic, which is really the greatest public health threat of the century, that if you don't link it to COVID-19 response or pandemic in some way, any initiative could be almost go on the back burner, right? So I think from a tactical standpoint, there has to be some link to the pandemic. Now, I would say that it's not a forced linkage. In fact, there's actually a robust amount of shared resources between these two things. So let me get into that. Next slide, please. So most of you know the slide, the picture on the left. There's this sort of a steep surge of COVID-19 patients. And then the dotted line that's horizontal is the current capacity of health systems to treat these patients. And then the idea of the flattening the curve is to bring the peak of that curve, the surge of patients, below that current capacity. Because what happens when the capacity to treat is exceeded, and we're seeing this now in the US in some states, unfortunately, again, is that hospitals have to ration care, ration out ventilators. This is incredibly sad when you have to do that. So the idea is to try to either reduce the surge of patients by social distancing measures and things like that. But the other strategy is to try to expand the existing health capacity, the treatment capacity, and most people think it's very static, but I would argue it's actually quite dynamic, and we'll get into it in the next slide. And I just put the picture on the right as it just came from yesterday. It's looking at the daily new cases in Europe and United States, and the first bump we thought we were flattened the curve. But we're now exceeding that, the first curve, second curve, and now we're setting new records. That slide is more of is designed to show really the need for public health measures, but also over-reliance on health systems to treat, and we're going to exceed that even in the richest countries in the world, like US. Next slide, please. Oh, can you go back? Yeah. So if you put a Venn diagram, right, with the pandemic treatment capacity in one circle and surgical capacity, and see where they have shared resources, we could break it down into 3 S's. Paul Farmer loves to use the space, stuff, and staff. So when it comes to space, surgical capacity, we have hospital beds that are dedicated to post-op care, post-anesthesia units, intensive care units. These are all infrastructural assets that can immediately be turned into pandemic treatment capacity whenever it's needed. But even more relevant is stuff. We have ventilators, oxygen, personal protective equipment. That's all part of surgical ecosystem. And once again, by stopping emergency operations in these existing health systems, and you can reallocate, reposition surgical capacity almost immediately into treating the surge of COVID patients. And then we have our most valuable asset, which is really our staff. Anesthesia, there's an article that just came out, and I'll show the link to it a little bit later. There's a demand, 4 to 5-fold demand for anesthesia personnel right now. And there's no surprising. COVID is a pulmonary disease. Nurses, surgeons can be retrained, believe it or not. We can be retrained to take care of pneumonia patients. That's not a hard thing to do, and they've done that successfully. So as you can see, there's a incredible amount of overlap between surgical capacity and pandemic treatment capacity. And countries and health systems that already have existing surgical capacity were they're successfully repurposing that to meet pandemic needs. And then for purposes of building up surgical systems in low-income countries, this makes perfect sense to use pandemic treatment, pandemic preparedness strategies and link up with them as a shared vision for surgical system strengthening. So in fact, we think it's one of the best buys. So let me get to the next slide, please. So WHO recently published this piece in June. It's called Investing in and Building Longer-Term Health Emergency Preparedness During the COVID-19 Pandemic. It's an interim guidance, but they give you some instructions to the member states, to the ministries of health, how to prepare for now and also in the future. And they specifically deal with, as one part is the health system part. There are other parts as well, like surveillance and testing and all that kind of stuff. And what it says is making investments that will enable them to close specific health system gaps in order to deal with such stresses. And we're talking about such stresses as overwhelming number of pandemic patients coming into the hospital. So I just put a great example of an NSOAP. This is obviously the Zambia plan on the right, and to show that it has to be integrated at the policy level. So and this is so important, and this speaks to the need for a level of sophistication and governance and management capacity within ministries of health to be able to do that very, very effectively. These integrations do not happen without actual people talking to each other. It has to be intentional. And so next slide, please. And why is this important? Because there's only a set amount of money that we have to devote to pandemics, surgical systems, so on. The LMICs are always challenged by competing priorities, not enough money, underfunding in public goods, and invisible outcomes. But when it comes to surgical system strengthening, as evidenced by, the first step being in the NSOAPs, at least with the pandemic preparedness, we are not competing priorities. We're actually aligned in those priorities, and we actually have similar outcomes. We can provide treatment capacity that's tangible, that's both, that's the outcomes in surgical system strengthening and also from a pandemic preparedness standpoint. So in that way, we think if pandemic funders are going to try to support LMIC pandemic preparedness, and they want to invest portion of it in health system strengthening, surgical systems investment is one of their best buys. And I just want to point out an excellent article written by Laura Hemeke and Craig McCain. It was just published in Think Global Health. They go into this a little bit more in detail. I also wrote a shorter piece on it on Global Health Now. And we're trying to get this concept developed from an advocacy standpoint, but then there's also a technical component to it. How do we actually operationalize pandemic funding to the scale of surgical services? And if you want to hear about that, you should come to the next webinar on the financing. So thank you for your attention.
Thanks a lot, Keith. That was a fantastic talk. And I think that you really highlighted the fact that, surgical services have always been around and exist. It's just trying to ensure good entry points that the rest of the national health priorities recognize that. And I think it was Winston Churchill who said, never let a good crisis go to waste on a pandemic. But I think in this case, the COVID-19 pandemic has really brought out or highlighted a lot of really important aspects of surgery that, as you say, from an advocacy standpoint, we can capitalize on it and highlight and get the attention of policymakers. So let's turn our attention next to our third speaker, Dr. Walt Johnson. He really needs no introduction, but for those of you that don't know him as well as we do, he's a US trained neurosurgeon. He's currently a professor of surgery, neurosurgery, and public health, as well as the founding director of the Center for Global Surgery at Loma Linda University in California. And prior to this, he is very well known for leading the Emergency and Essential Surgical Care Program at the World Health Organization from 2015 and 2019. And during that time, Walt really tirelessly championed improving surgical access for all. And I think he's really brought the visibility of global surgery to an international level. And I'd like to just thank Walt for that right off the bat. He also was the vice chairman of neurosurgery at Loma Linda for over a decade prior to taking on his public health advocacy role. Welcome, Dr. Johnson.
Thank you, Catherine. It's very nice to be here today. I appreciate the invitation from UNITAR, GSF, PGSSC, J&J. It's certainly nice to be here with everyone that's my friends here on the panel. First slide, please. I would like to take a step back, looking at how the NSOAP should fit in with national health strategies. At WHO, we call national health policy, strategy, or plan because each member state has a different term, whether it's a policy, a strategy, or a plan. So we just kind of lump them all together, calling them national health strategies or policy, strategy, and plans. Next slide, please. The concept of NSOAPs really came from the Lancet Commission on Global Surgery, and they outlined in broad brushstrokes planning joint efforts in forming a plan through a surgical forum, and then the last stage of implementation, which includes monitoring and evaluation and whatnot that Emmanuel spoke about. But the planning stage is really a critical stage of how do you get the right people on board? How do you develop the right political connections? How do you embed the national surgical plan within the national health policy, strategy, or plan? The next slide, please. So the pillars of NSOAP are really all the aspects of how the health system should work in developing surgical care. Surgery is not a silo that you can just perform surgery independent of all other aspects of medical care or service delivery. It's part of a whole national health system of service delivery, and includes the infrastructure, all the things that we need, equipment, the health, the human resources for health at all levels, information management, financing, and lastly, governance. So it's all run in a coherent and a strong way. Next slide, please. WHO has resources, as you know, in the World Health Assembly resolution on strengthening emergency and essential surgical care as a component of universal health coverage. Built into that resolution was assisting member states in developing health policy. It was part of that resolution. It was part of the mandate of WHO to help the member states develop these health policies. It was also written into the resolution that the member state had certain obligations to develop their national health policy, strategy, and plan that would enable them to deliver surgical care and anesthesia. These are some of the tools. There's a whole team at WHO on developing national health policy, strategy, and plan. They have many tools available. They have technical expertise. They can assist member states in doing this. And these are all available on the WHO website. Next slide, please. So now that we've looked we mentioned the building blocks, we have to get all of these building blocks into a firm foundation to develop this national health policy that includes the NSOAP. And as we mentioned, you have to finance it. You have to have workforce that is not going to work for free. You have to have ways of developing that workforce, not only through training, but then give them jobs afterwards. Information, you have to develop the evidence in which to base these policies so that you can convince other people in the government that this is a really good idea. You can't just say we need to build up surgical care and people just automatically say, well, that's a good idea. You have to have evidence and convince them of that. You have to have supply chains, logistics, get medicines, vaccines, technology to where it's needed. You have to have hospital system set up so that it covers the majority of the population so they can access care readily. Maintain the facilities, have electricity and running water 24 hours a day so it's dependable. And then leadership, not only to set everything in place, but the governance to make sure that it stays in place and that it stays functional and has excellent quality. The next slide, please. You have to get the correct stakeholders on board, and the stakeholders are anyone that has a vested interest in surgical care, from not only within the government, we think in terms of Ministry of Health, but it also includes Ministry of Finance, Treasury. It includes education. Many countries, for developing a workforce, it's tied in with the Ministry of Education for residency training. And so you have to include them. At WHO, we did a short, very small study looking at electricity, running water, utilities, and energy, and the delivering surgical care. And at the end of the day, we found out that none of the SDGs will ever be achieved without having proper amount of energy. So getting the Ministry of Energy on board, getting the clean water, et cetera, to the district hospital is the key ingredient. Getting NGOs, the nonprofit sector, anyone, the community groups, activists, business and private sector, political parties, local government, you have to have champions that will say, yes, this is important, and work on the not only the political arena, but in the finance, otherwise bring a coalition together that can fight for these things. United Nations agencies such as WHO, UNITAR, UNICEF, things that have vested interest in outcomes and promoting health for surgical patients. Next slide, please. And then you have to think in terms of anchor points. How, if you have a national health policy strategy or plan, you can't just divide it in the middle, splice in an NSOAP, and then think that everything will be fine. As was stated previously, aligning priorities between government agencies, integration into that national health policy strategy and plan. You have to be able to share resources and leverage resources to advantage so that they can accomplish more through the synergy of people working together than they would in a standalone position. And then develop the correct political coalitions to carry this forward. So what do I mean by anchor points? Next slide, please. Well, the National Health Policy Strategy or Plan will include various other aspects related to health. So there'll be aspects, and it changes with each member state. Some member states will have funding available, they'll have a priority, cervical cancer, for example. Well, then you need to anchor the NSOAP in that area with the cervical cancer program, or prostate cancer, breast cancer. With diabetes, diabetes is, or all of NCDs are now an issue in every country in the world. Even the low-income countries are now seeing NCDs as among the top 5 of things that are increasing their mortality rate. It's not communicable diseases anymore. So link in with each of these programs. Injuries is a huge issue with most member states. You have to link your NSOAP in with that part of the national health policy that actually already exists. Communicable diseases. Many sub-Saharan Africa programs or countries have HIV/AIDS programs, and linking that in with that infrastructure and with that health policy through what WHO calls voluntary medical male circumcision for adults, reduces the heterosexual transmission of HIV. Link into that part of the national health policy. And of course, maternal health, children's health, and as was mentioned earlier, emergency preparedness and disasters such as COVID. But anchoring your NSOAP into as many of these areas as possible secures it within the national health policy, strategy, or plan, and makes it much more sustainable and makes it much more viable. The next slide, please. Sometimes it behooves us as surgeons or advocates for surgical care to point this out to ministers of health. I had an occasion once to ask a member state, well, do you need help with surgical care development in your country? And they said, no, we're fine. We're really fine. So I asked, what are your major health issues? Well, we have high maternal mortality. We have very high child under 5 mortality. We have extremely high injury death rate from road traffic accidents. And I had to connect the dots for this person in the Ministry of Health saying, well, maternal health, reducing maternal mortality requires an obstetrician or a surgeon and anesthesiologist, someone that can stop bleeding, that can do C-sections, that under 5 mortality from congenital malformations, from injuries in children, road traffic accidents. You need trauma surgeons. And once I connected the dots to bring their attention to all of those require some type of surgical care within the surgical health system, the lights come on. They say, well, of course, yes, please come and help us develop an NSOAP. So we need to be advocates and show how surgical care relates to all those different aspects, just like I was mentioning, anchoring them within the national health policy, strategy, or plan. And then the National Surgical Forum, bringing everyone together to address these health problems, bring in all these key allies that from all these different programs, and making it truly a cross-cutting horizontal way of building up the entire health system. Every person's programs have to be addressed through the NSOAP. You can't just say, well, trust us, we'll carry on your program fine. Everyone has to be taken seriously. Program plans have to be informed by realistic assessments. Priorities must align with other national programs, as I mentioned. And then there has to be a clear strategy with clear targets, clear goals, and follow up on that with realistic monitoring and evaluation. Next slide, please. Lastly, I would just like to point out a WHO monograph that was done that's on the WHO website, but it highlights case reports on developing NSOAPs in a number of countries, and in parentheses, it includes our key allies in developing this. Mercy Ships, Royal Australasian College of Surgeons, Pacific Island Surgical Association, Operation Smile, Association of Rural Surgeons of India, and many others, that just highlights how national surgical plans can be developed in each one of these countries. But it's a whole of government approach. It's not just an isolated system where surgery develops its own silo, but it's something that has to be anchored into the national health plan, and it has to be anchored at multiple locations so it has traction, it has sustainability and longevity. Thank you very much.
Thanks, Walt. What a great talk. And, you know, I think you really pointed out that the key is to try and make surgery relevant to other aspects of a national health plan, because many of us in countries that have very little money for increasing health programs by pointing out the relevance to existing priorities already, I think can be a way in. And I think there was a very relevant question from South Sudan saying that they also have very marginalized health system, and how do we incorporate surgery, obstetric and anesthesia care into that? And I think your example of pointing out the high maternal mortality, injuries, ways that a strong surgical health system could alleviate some of those problems is a great response. I just wanted to first say that regretfully our fourth speaker, Dr. Sarah Madzangezi from Tanzania, is unable to join us. She was actually instrumental in helping with the NSOAP there, but today they have their elections, and so she was unable to join us. Also, I know that Dr. Walt Johnson does need to leave a few minutes early, so I'll direct the first question to him. So Walt, you know, you've made a nice blueprint into at a national level how NSOAPs can be integrated in the anchor points. And I was just interested at the international level when you were at the WHO, how did you elevate the status of essential and emergency surgical care? Because kind of when you started in 2015, it was I don't want to say a little office off by itself, but you know, essential and emergency surgical care was sort of seen in a silo. And how did you then at that international level go about trying to make alliances or find common ground with other health priorities that might sort of have more international attention?
Well, as you know, and can easily imagine, a single person sitting at a desk in Geneva can't change the world very effectively by themselves. I'd like also to bring your attention to the Millennial Development Goals and the Sustainable Development Goals. The 8th MDG and the 17th SDG are both about developing partnerships. And nothing can be done, particularly with NSOAP processes, without developing key partners and getting a coalition of people that are all driving a particular agenda or driving towards particular goals together. So there were two key groups of partners. One was internal to WHO, getting links inside of WHO with maternal and child health, with emergency and trauma care, with NCDs, and a number of different programs that are strong programs. We developed Ebola guidelines. We did work on new updated guidelines for voluntary male medical circumcision, et cetera. So we developed strong internal bonds, and also got surgery on the global program of work, the 13th 5-year plan of what the WHO's agenda is. Actually mentions surgery and anesthesia now, first time ever. And then externally with ministers of health, Zambia, the Republic of Zambia was a strong partner with us. Professional societies such as the Royal Colleges of Surgeons, the College of Surgeons of East Central and Southern Africa, and Western Africa College of Surgeons, etc. Academic programs like PGSSC, getting key partners that would join us in pushing the agenda of surgical care was absolutely vital. There was no way that I could have done something by myself, sitting there just saying, well, I'm WHO, you have to listen to me. That's not how it's done. It's internal partners, external partners, everyone coming together to make a difference.
Thanks for that, Walt. The next question comes from the Q&A, and I think it's a great question asked by Ram K. Shah. And actually, let me address this to Jeff first, because you're also from an international organization. The question is why national governments are reluctant to implement the suggestions by international bodies? And then the second part of that is there any way to enforce them to do so?
Well, thanks, Catherine. I think it's a great question. And I guess the answer comes back to a lot of what has been said by our speakers. Number one, advocating with the ministries of health, because I honestly think that they don't necessarily have it on their radar. And one of the answers that we repeatedly hear is that surgical care in the broad context is so broad, so cross-cutting, it's hard for people to wrap their heads around it. So to target in, like Walt said, on anchor points, or I use the term entry points, to focus in, like cervical cancer, maternal health, that all of a sudden makes sense to the people in the Ministry of Health. So then you grab their attention, and then we have to be able to articulate the fact that if you answer the question with an NSOAP for cervical cancer or maternal health, there's this massive spillover of benefit for the whole breadth of surgical care. And those two messages need to be communicated clearly and effectively to ministries of health. Now, one of the things I was also thinking about is it's not just the Ministry of Health, it's the Ministry of Finance. They're the guys who need to get the buy-in, because on the one hand, they're going to be paying for it. On the other hand, they're going to be saving the millions and millions of dollars of lost economic income from upscaling surgical care. So I would say those are the two keys. Enforcing it, I think that becomes a political question. And you know what? I'm going to pass that baton to Emmanuel, because Emmanuel was involved with the resolution 68.15. And so here, all the member states, all those ministries of health actually adopted that resolution. Now, how do we hold them to that commitment? Emmanuel, let me pass it to you on that one.
Thank you so much, Geoff, and indeed you've really covered most of the key issues about it's not really, for me, like you've said, it's not so much that the member states are reluctant to implement or unwilling to implement, because the member states tabled this issue themselves. It did not come from anybody else, it came from the countries. And they didn't do it once. They did it in 2015, they did it in 2017. As you saw, there was a decision point that followed up, and the commitment they made in 2017 runs all the way to 2030. And they have to keep reporting every 2 years on what they're doing. Somebody who's not committed wouldn't do and tie themselves like that. Now, the commitment they made is a political one. While, of course, it's not legally binding, it is born of the problems that they have themselves within, and they're trying to move forward. I think what has lacked more, which has made the process slow, is what we still are lacking: global coordination, and we are lacking regional coordination and support. While the countries have committed to do that, they don't know how to do it, because it's never been done before in many countries. Like we said, everybody's used to developing silos of vertical program. It's very easy to establish a malaria program from the top all the way to the community. But how do you develop surgical services which are cross-cutting? They've got so many entry points. They involve so many partners. Most countries don't know how to do that. They just simply don't have the expertise. When we look at the surgical teams ourselves through professional associations, we are also always focused on our own academic staff, publishing to ourselves, talking to ourselves. We don't know how to engage with policymakers. We don't know how to engage with development partners. So there is handicaps on both sides, on the ministry side and on the professional side who are supposed to help. So it's a learning curve that all of us to try and learn. We're learning how to do politics. We're learning how to talk policy. We're learning how to develop programs. We're going outside our operating theaters, in short. While we also need champions that can also pinpoint and help government to see that if you want to reduce maternal mortality, which is mostly caused by bleeding complications, it's surgical services that you need, and anesthesia services and critical care that will help you prevent that death. If you want to reduce fistulas, if you want to do anything, you need a bit of surgical services. So the entry points will be many, and that's why we're presenting this in webinar, to discuss how we can do it and how we can support the countries, because they are committed. Yeah.
Thanks, Emmanuel. There was an excellent question in the chat about pandemics and sort of sharing surgical services. But Key, I wanted to ask you, you know, we've mentioned that the pandemic has brought out how the importance of surgical care and surgical system strengthening. But I do feel like every discipline has been saying, because of the pandemic, this is why you need to strengthen services around NCDs, services around TB. Here in South Africa, there's been a big push that people are not getting their TB medication, for example, because of the pandemic, and how important it is to strengthen that. And I guess what I wanted to ask you is, what kind of data do you think we need as the surgical anesthesia and obstetric community to make our case? Because we keep saying, yes, okay, we wear masks, pandemic needed masks, we have anesthesiologists, they need anesthesiologists, but to play devil's advocate, at least in Africa, there weren't that many people that needed to be intubated. So, in terms of a pandemic preparedness, why surgery and not other health system strengthening areas?
Yeah, it's a great question, and let me just let me just go dive right into some of the data part. We have, I think it's clear that the money that's being put forth to help countries, LMICs, build up their pandemic preparedness is coming down the pike. The World Bank has announced it, the European Union, there's a lot of money coming down. Not as much as there should be, but there is some. And some of that money will be allocated towards health system strengthening. And we're arguing that if you're going to strengthen health systems, why don't you invest in surgical systems, which can, when in pandemics, be useful, but at the same time, when there's no pandemic, provide surgical services, which benefits all other aspects, right? Injuries, children's health, maternal health. So let's talk about metrics. Our numbers for measuring surgical capacity is 2-hour access, surgical volume per 100,000, SAO density. Those kinds of metrics kind of ring hollow when you're looking at it from a pandemic standpoint. They're more concrete. So we are actually in the process of converting, let's say, 5,000 operations per 100,000 to sort of a recommended benchmark from the Lancet Commission on Global Surgery into number of beds, hospital beds that will be required. So we think that so each country will have a number of current gaps in terms of how many beds will be required to address, meet 5,000 operations per 100,000. That can in turn be used to calculate the cost of scaling up those services in the country as part of the pandemic strategy and be budgeted. So I don't know if that makes sense to you, but we're trying to take the metrics for surgical capacity and make it more translatable for pandemic funding.
Yeah, no, thanks for that. That's a great response. There have been several questions, Emmanuel, in the chat, kind of, I think, from folks in different LMICs who are at the stage where they want to start an NSOAP. They're not sure how to get the buy-in from key high-level stakeholders. And the case of Zambia is always touted as a success story. And I think that it would be nice, Emmanuel, if you can share kind of the steps that you took, and perhaps why it was quite unique in the position you held, and kind of the ability to get the NSOAP integrated right away into the National Health Plan. And then the part of that is, at the same time, did you have any major stumbling blocks that you could share with us that, those of us starting out our NSOAP process, it could be a good lesson learned? Thanks.
I would like to start by saying that no one size fits all. Even in the Zambian scenario, if we were to repeat the process today, it probably will not run as it ran then, because even within the same system, different times we achieve and give different results. For us in Zambia, I think it was a matter of alignment. Everything was aligned. The superstitious ones would say the stars were aligned. So everything was totally aligned, in the sense that I went to Geneva as an expert coming from senior management in the Ministry of Health, and I had certain mandates from my minister on what we were supposed to be taking forward. One of the key things we're supposed to be solving was the issue of surgical capacity, because we had already analyzed from the MDGs that we're not going to meet our MDG targets, especially on maternal mortality, because we did not have surgical capacity close to the people. So mothers were dying because of bleeding, and there was nothing to help them survive. So I went to WHO as a diplomat with the mandate of also trying to solve or help my country solve that problem. So when we engaged with WHO, we realized that there was one person running the emergency and essential surgical program, and they did not have any other things except a tool of assessing the baseline of surgical services in the country. So WHO itself was handicapped, and there was no resolution to do with that. So we had to start from zero, working with everybody else, first of all, to get a resolution, because that resolution then would guide the support that could come and also would guide us with something that we can work to develop that. So you can see there was already alignment and need coming from below before it went up. So once we got the resolution, because we shared the resolution, we negotiated the resolution. So we had to run with it now because we had something to take it down. And again, it was alignment that I was incorporated into the global surgery, the Lancet Commission at the very end. So I was part of the Lancet Commission, and the Commission had already done a lot of work on how you do baseline and even the framework of how you can try to start developing a national surgical plan. But they lacked where to pilot it. So I happened to be in that meeting, and boom, they are looking for where to pilot, and we're looking on how we can do it. So it totally went together, and I contacted my minister. And so we were then quick to go ahead and pilot the framework that had been developed by the Lancet Commission. And so once we did that, and again, we had very good directors within my ministry that were really keen to try and do this work. They also quickly took up that challenge because I could not direct and work in my country while I was in Geneva. It took very dedicated people, the permanent secretary, the minister himself, and their directors who were very willing and wanted to solve this issue, to then take it on and bring any opportunities I was able to negotiate and pick up from around the world to the country. And so they moved very quickly with a lot of partners, and they wanted to do this. So they did the development of the NSOAP within 6 months. That was because they wanted also to finish it so that it's already integrated, because they knew that developing an NSOAP that's not integrated would not get us anywhere. So it was a matter of alignment and having champions who already believed in this work, both at the international level in diplomacy and at country level, and in the professionals that were willing to come and sit through meetings for a long time with no payments or allowances and deliver the document to government. But for those that want to start, of course, it always starts with, first of all, they have to be champions. They have to be people who want to do this work. They really don't have to be, one person can always infect others with their passion. So there's need for somebody or a few that want to do this. And usually the professional associations and the experts themselves know the needs of surgical services within, and they know the linkages. So they have to then start already partnering with others in public health, but then they have to do a baseline because there's need for evidence. You cannot be championing something without evidence. You have to do a baseline to highlight the gaps and what is available already and where you could go. Of course, discussing not the negative part of it, but the benefits of what you could get from it. Yeah.
Thanks. No, that's great. There have been a couple points in the chat that I wanted to, in the Q&A that I wanted to highlight. One was from Adrian Gelb from San Francisco. He made a comment, healthcare is a political issue in every democracy. How does one engage the public in lobbying for an NSOAP? And I think that point is quite important. Here in South Africa, the issue around ARVs, antiretrovirals for HIV-infected patients was not at all on the government agenda or radar until the public began demanding antiretrovirals and really pushed the government. So I think that's a real grassroots kind of push. And so one question to the panelists would be about how do we get the public involved in that? I think my own comment around that is I think that it's hard to get behind surgical systems strengthening as a simple message a lot of times. I think sometimes the vertical programs, you can kind of just envision, like specifically for a condition like breast cancer, you can kind of envision what the patient looks like. Perhaps that could be one of the challenges. And then a link to that, there was another question about how NGOs can get involved. So on Walt's slide, he did mention Mercy Ships and OpSmile as 2 NGOs that could get involved. But perhaps, Jeff, I'll direct the NGO question to you. And then Key and Emmanuel, I'll direct the question about getting the public behind the NSOAP process to you guys. So perhaps, can we start with Key on the question about the general public?
Sure. I can't help just look at this panel and, we're 5 years into the global surgery movement, right? The resolution was 2015. And we can't drive social change, really, a global social change by a bunch of surgeons, obstetricians, and anesthesiologists hanging out in the surgeon's lounge wearing our scrubs. And that's what's really been happening, right? So at a very least, so we're in academia, I would encourage academics in global surgery to actually reach out to the other parts of the health system, right? And actively engage in collaborative research with injury specialists, the maternal health groups, really make that link happen. If you're an NGO, maybe you could think about collaborative programming, right? Let's say, jointly with the injury reduction groups and trauma surgery. So there's creative ways to make those linkages beyond the surgical system. And then if you're, so if you're a funder, fund events that actually helps de-silo these groups, right? Force those things to happen through push and pull mechanisms. So I think those are some of the ways I think we need to move forward because it's, at the end of the day, integration is not going to happen. The entropy is really for us to just hang out in our lounges.
For sure. Emmanuel, anything on that?
Yes, indeed. We can't really move this agenda, like he said, only ourselves. So first of all, we have to stop only talking to ourselves and start talking to the bigger group, to the bigger population. When we publish anything about NSOAPs or surgical services, whether it's the burden or the impact, we publish in scientific journals that we read ourselves. We don't publish in the newspaper, the common man's newspaper. We don't publish in any magazines. We haven't done that. So that is a problem. Like they said, it's very true that unless this thing comes from the population, the movement and the progress will be very, very slow. Now, how much do the population know about surgical services? We may ask ourselves. Pretty nothing, almost nothing. In fact, some of them are very scared of surgery. So we have to see how then, and do we have the capacity to engage the community? Most of the time we don't. And that's why the work of the NGOs becomes very, very important. And we're not only talking about the NGOs that are also part of us, that are providing surgical services of some sort. No, we're talking about the NGOs that engage and mobilize the grassroots. Catherine, you clearly said the South African HIV movement did not move until the community got involved. We have to get the NGOs that can work on the community to educate our people about surgical services and to get, please go away. I'll come to you later. Okay, say hi to everybody and then go away. Okay, so until we get those NGOs to be involved, and they have to educate the public about surgical services, because sometimes people also don't know that the condition they have is a surgical problem or that it could be treated with surgery. So we have to educate the people about surgical conditions, that it's cost effective, that does not kill you. Yes, may be painful, but we have the medicines, and that it can also help you to become more active physically to prevent other diseases, and also economically more active, because if you have a hernia, you can't grow your food. If you can't grow your food, you have no food security, you cannot sell anything, you have no money, you cannot send people to school. So it's all connected. But we need NGOs on the ground to talk to the community, to try and bridge the gap between ourselves as technocrats who know so much and the population. Because once the population know how precious and how important this tool is to their health and well-being, they will start demanding it. They will ensure that the hospital that is built in their constituency does have a surgical capacity, because they don't want their mothers to come to that center and then be put on an ambulance, a 4x4 ambulance in a hotbed, and transported for 1,000 kilometers, and then deliver in the process, end up with a dead baby, and end up with a fistula themselves. They have to be educated so they can start demanding this themselves.
Thank you. And I think that the point you make about the NGOs is really good, because, for example, here in South Africa, we've been looking at what community groups, what NGOs already exist around patients who have had surgery, and we can find nothing. But then when we asked around, actually, there are already community groups around disability, for example, and many of those people were injured, but they had no idea that this was actually related to surgery. So if you just go out and say, let's start surgery community groups, then you kind of get blank looks. But if you speak to something that groups that already form, and I think that Walt and Emmanuel, you both kind of said the entry points or anchor points. And I think that, for those of you kind of just starting out in the process in a lot of LMICs, and you feel really kind of frustrated and helpless, perhaps tapping into groups that already exist rather than needing to create one's own would be a great starting point. Jeff, over to you about either NGOs or kind of rallying the public.
Well, thanks, Catherine. And I think Key and Emmanuel have said a lot in that regard, but I want to just go back to the word integration. We're talking about integration, and the overall topic of this session is integrating an NSOAP into the National Health Strategy. But when we look at integration as in a broader context, we're talking about integrating the public, like what both Key and Emmanuel said, integrating other ministries like the Ministry of Finance. And like Key, you were saying, you know, us surgeons sit in their scrubs in the doctor's lounge complaining about these things. Integration also means us surgeons and anesthetists and nurses getting out into the greater global health community and making sure that the message is understood there as well. And I just want to touch on that point. I know Adrian's on the call, and I saw another question earlier in the chat, the Q&A about anesthesia training. When we're talking about NSOAPs, we're not just talking about surgery. I don't want anyone to get the wrong idea. This is about obstetrics. This is about anesthesia. We as surgeons cannot do surgery without safe anesthesia. And training in all those areas is so important. And I was just looking at some of the Q&A, and Solomon Berra from Kenya has pointed out something very interesting. He says, I work in a very remote, far-flung hospital with no surgeon, yet we have immense surgical needs. And Solomon, I gotta say that your situation is not unique. There are dozens and dozens and dozens of hospitals all over, not just Africa, but in Asia as well, where there's enormous surgical need, and you have a physician, maybe an MD-GP or whatever your country calls it, who has very minimal training. And how do we deal with these surgical needs in countries like where your setting is? And so the NSOAP in these particular settings can start addressing the training requirements to meet some of these needs at the small remote district hospitals. And I don't want anyone to go away from these sessions thinking that we're training high specialty surgeons for the tertiary care centers in the capital cities. What we want to do is look out to the district hospital level. The lion's share work is done in the district hospital level. And I know, Catherine, you would have a few things to say about that as well. So we need to get that surgical capacity out to where the people are. And that example that Emmanuel just gave about traveling 1,000 kilometers with obstructed labor, ending up with the baby dying in a fistula, that just should not happen. And we need to get that surgical capacity for the basic bellwether procedures out to where the people are. So in terms of integration, all of the different parties, the NGOs, the mission hospitals, the government hospitals, we all have to come together to work together to achieve that goal.
Thanks for that. And I think that the other thing, when we talk about the community or the public, I think as surgeons, obstetricians, and anesthetists, we also must remember that one of the biggest barriers to doing surgery in district hospitals by non-specialists is ourselves. So many district hospital doctors are afraid to do any type of operations because they're afraid of the criticism and the lack of support by specialists at higher level hospitals. You know, oftentimes if something goes wrong there, they will be transferring the patient to the tertiary hospital where the specialists work. And sometimes the specialists are quite critical and don't want to promote the district hospital services because they just say, well, you're not a surgeon, you're not an obstetrician, you can't do it, just transfer all the patients. But then in the same breath, also complain about the long waiting lists and the inability to operate on all the patients that get sent. So I think that when we speak about the community, I think that, you know, we are used to working in our silos, sitting in the tea room, waiting for the patient to show up in theater. But I think it is quite important to get out there and speak to our family physician colleagues, our mid-level provider colleagues. And I think that's a real mindset that needs to be changed, because I think sometimes we're our own worst enemy on that one. There have been quite a few questions from people about sort of technical support, starting out in NSOAPs in their different countries. And I don't know, Key or Jeff, you want to touch on the sort of the NSOAP series and then the manual that's out? Key, I don't know if you want to discuss that.
Yeah. I was just typing an answer on the question and answer chat box, and it's a brief, very brief answer. Member states, they're all signatories to the resolution from 2015 and the decision point 2 years after. they are mandated to actually implement this resolution. And then they need help. They have the right to ask for help from WHO, and they have to respond. So the most effective way that I've seen is for the Minister of Health, him or herself, actually write a letter requesting technical assistance from the WHO representative in the country, copy any one of us would be great, but copy the regional office and the headquarters, and that gets kicked up right to the top, and they have to respond. And this is now one more point I want to make about WHO. Yes, they're overwhelmed with the pandemic response. No question about that. They're doing a great job, but they cannot neglect their duties as their own mandates in implementing the resolution. And right now, there's no one at the WHO taking care of emergency essential surgical care, and they have to fill that position. And I want to make sure that that message gets to them very strongly.
Thanks. Jeff, do you want to say anything else about the series? I see you've posted the web link on there, but do you want to talk about it a little bit?
Yeah, a lot of the questions have been great questions. I've been trying to type in some of the answers, but the issues about the role of NGOs, professional societies, academic institutions, that will be one of the focus of our, not the next one, but the one following in late November. And the next session in 2 weeks will be related to financing, which Key, again, is going to be leading that team. So there's, please visit the Global Surgery Foundation website. It's all listed out there. And I believe that if you've been registered for any of these sessions, you automatically get a reminder for the upcoming sessions as well. So we'd love to have the participation of all of you. They promise to be some very interesting discussions, and yeah, and then in the new year will be the final session will actually be about the steps needed to kickstart. There was a few questions, one from the Sudan about, well, how do you go about getting this process started in my country? And I think a lot of people are probably asking that. And you may be surprised, maybe it already has started and we just don't know about it. So that last session in January will be focusing on that topic. So please join us for those. But yeah, thanks, Catherine, and please carry on with some of the other questions.
Well, I was just going to say, I think we are sort of a few minutes over our time, and I wanted to thank all the panelists. And I thought I would ask each of the speakers if they have any parting remarks, and starting with Emmanuel and Key, and then let Jeff wrap it up. But I just wanted to say a fantastic session. And I think that, you know, we've received some really important tips and sort of blueprints about how to integrate the NSOAP into the National Health Plan. But I think that a lot of people in the audience believe that, but then they're not so sure. And I think, Jeff, your session in early next year will address that. How do you get that kick started? I think, you know, in South Africa, we held our National Surgical Forum in 2015, but it really took until this year to get the Ministry of Health actually interested. And then we have a Treasury, and not Ministry of Finance, but something similar. And that's the next buy-in that we're really working on. So I think those are all really important next steps of how do we actually do this. Emmanuel, should we start with you? Any parting comments?
Yes, thank you so much. Mine is just to indicate that the integration of the NSOAP is really important. It's not possible to develop an NSOAP that stands alone because the entry points are many. Integration should be thought of even from the inception when you're starting, because it involves the stakeholders that you bring together, the ministries. And like Geoff said, it also involves us going out ourselves as the people in the global surgery movement to go and engage with others. So at the formulation of the idea, integration should already be thought of, and the people should be included. And then policy level, it's not just the health strategic policy that integration should be targeting. It's a lot of other national documents that are already in place, and we see, because their main entry point, surgery contributes to the outcomes that these documents are looking for. And also they should be alignment, because the surgery should not be pointing this way and the other documents are pointing that way. It won't happen. And then we have to follow through to programs. Once we have the policy, let's not think that automatically they need to run. We have to ensure that we can insert and contribute at entry points in the programs where where it can be done, and of course at service delivery, targeting the most problematic issues that the government and the people are faced with. They're faced with a lot of morbidity and a lot of mortality from trauma, from cancer, from the pandemic preparedness. And let's preach, while we're talking integration and talking engagement, let's be positive about it. There'll be frustrations, it's not a sprint, it takes time, but let's be committed, let's be serious, and let's be positive. Even our advocacy should be based on evidence, but let it be positive. Thank you.
Thanks. Keith?
Yeah, I'll just want to mention that based on the question and answering session, I get a much more better feel of who's on this call and what the needs are. And I just want to emphasize, I did place my email address on the Q&A, but I also want to make sure that if there's a mechanism to let a follow-up email go out to all the participants, I give my permission to release my email. And the PGSSC, our mission is universal access to surgical care. And so if anyone wants assistance in any way, even if we can't do it ourselves, we'll make sure we find the right people to help you.
Great, thanks for that. And then finally over to you, Jeff.
Well, thank you, Catherine. This has been just a fantastic discussion. And I must say, I'm having trouble keeping up with the question and answers. This is great. It really indicates that we've got a dynamic discussion going, and I really want to thank all of the people who attended the session, and it's a testament to the great speakers that we had today. So thank you very much. And I would just like to again say thank you to Johnson & Johnson for their support for this entire series, without which the support, it'd be hard to conduct it, and to UNITAR, and from the Global Surgery Foundation. We really are excited about the NSOAP manual being published, and it is available online at our website. And yeah, we look forward to seeing you all in the next session. So thank you very much. With this, I will conclude the session. Thank you.
Thank you.
Thank you.
Thanks for moderating, Catherine. It's awesome.
Yeah.